Hello, this is Dr. Ballard. Today we're going to be going over the final lecture, which is putting it all together and taking the clinical decision making and developing a clinical judgment. So first of all, I want you to think about what is clinical reasoning. This is something that we've been working on all semester, and part of it has to do with putting together all of the pieces that you've been learning about so far. So if you think about clinical reasoning, it's an analysis of the knowledge and information that you've gathered during your assessment, both the subjective and the objective information. So you put together your history of present illness, all of the past medical history, family history, social history, as well as the review of systems. All of that is your subjective data, and your actual physical exam, which is your objective data. And along with that, you would look at any other kind of objective data that you might have, which could include previous lab work or lab that you've done in-house that day. All of that together you put into some sort of an analysis. What you basically do is you select and you cluster relevant information in order to help you decide on the outcome. You use your judgment, you use reasoning to interpret that data, and you formulate your A, or the assessment, which is your diagnosis, and then with that you will begin to put together your plan or your treatment. One thing to remember is that development of your assessment occurs in the clinician's mind and begins at the very beginning of the encounter when you first walk into the room. Remember how we talked about in the beginning of this class that you are gathering information all along the way. When you walk into the room and you look at the patient's affect, you look at how they're dressed, you look at whether they're lying on the exam table, whether they seem to be in pain. You're gathering information from the very beginning that is going to be part of your whole assessment. This answers the question, what is wrong with this patient and what are the problems or the diagnosis? And it follows similar steps each time. So you'll put together all of the information that you have gathered into this final assessment or diagnosis. The steps in clinical reasoning are listed below. First of all, you're going to identify abnormal findings. That might include abnormal findings in the history, review of systems, as well as on your physical exam. You're going to localize these findings anatomically when it comes to your exam, and then you're going to interpret them in terms of the probable process. And we'll talk a little bit more about that in the next few slides. You'll also make a hypothesis about this problem. You're going to test this hypothesis. It's called your working diagnosis. And then you're going to develop a plan agreeable to both the patient and to you as the clinician. Now, this testing of the hypothesis or coming up with your working diagnosis is going to occur as you discard your diagnosis based on the facts that do not support that particular diagnosis. And we'll talk more about that. So as an advanced practice nurse, you're going to build upon the nursing process which you already know about. Clinical reasoning is used in the nursing process. Basically, assessment is your data collection, and your nursing diagnosis is coming up with the problem and the cause, or the etiology. You also have signs and symptoms, body image, etc. For example, body image disturbance related to amputation. The nursing process includes planning or setting goals and prioritizing those. implementation or interventions, coming up with specific strategies for meeting those goals, and then we're always evaluating. Did we meet the goals? Were we successful? Was our treatment successful? So basically, this is similar to the nursing process that you've been using as an RN. It's just at a different level. So what do we start with? Well, we first start with identifying our abnormal findings. We're going to make a list of the patient's symptoms. We're going to look at the signs that you observed during your physical exams. You're going to look at any available laboratory or special test results. You're also going to look at those findings in your history, in your review of systems that were abnormal. Now, this particular slide is useful in terms of helping you kind of categorize the data that you collect. So you can localize your findings anatomically. In other words, symptoms that relate to one system, you would want to cluster those together. For example, a sore throat, inflamed erythematous pharynx, clearly localized to the pharynx. Some symptoms may not be as easy to localize. For instance, patients who present with fatigue or patients who come in with fever, but they can be separated into probable processes such as infectious versus neoplastic type processes. When you're trying to cluster these in your mind, you want to be as specific as your data allows. You want to interpret things in terms of the probable pathological process. Patients' problems often stem from processes involving diseases of a certain body structure. For example, a headache. It can be due to trauma, concussions. It can be due to subarachnoid hemorrhage. It can be due to brain tumor. It can be due to infections such as meningitis. It can be due to metabolic conditions such as diabetes, or it can be due to cervical degenerative disc disease. So basically what we're talking about here is trying to interpret things in terms of what process is going on and what is the underlying pathology. So think of it in terms of congenital, inflammatory, infectious, immunological, metabolic, neoplastic, nutritional, degenerative, vascular, traumatic, toxic, to name a few. So in other words, really try to break it down and ask yourself the question, what type of process is going on here? What is the underlying pathology that's causing this particular symptom and the findings that I'm looking at? Other processes that you might think of include pathophysiological. In other words, this means something that's gone wrong with biological functions. For instance, congestive heart failure is a derangement of heart functioning. Or migraine headaches. That can be considered pathophysiological. Psychopathological might indicate something like somatization. For instance, a lot of patients present with really vague symptoms, and they basically are a somatization of things such as depression or anxiety. For instance, headaches can be an expression of a somatization for depression. So can fatigue or lack of concentration or nausea or decreased appetite. Those can all be somatizations of other psychopathological conditions. So try to keep that in mind in terms of your process. Now on to the clinical examination. In the clinical examination, thus far we've been concerned with the initial interaction with the patient. We've tried to help you learn how to establish a respectful rapport with your patients, how to gather the important information through the history and physical exam and review of systems. Now the next steps that we're going to help you with are organizing, integrating, and preparing this information into some sort of logical way of looking at your data. So you've heard a lot of people talk about critical thinking. What do you think is critical thinking? Well, critical thinking is the process by which the information that you have gleaned from the history, the physical, the review of systems, all of that is merged with your clinical knowledge and your experience and the current best evidence. You use this process to help you formulate the next steps in patient care, and that is to develop the diagnostic and management plans. You're going to look at all of your evidence. You're going to basically, as a new practitioner and as a student, you may not have that experience to draw upon, but you're going to use your resources. You're going to look to your resources to find the most current best evidence. You're going to use the experience of your preceptor to help you merge all of this clinical information together. Critical thinking helps lead to the potential diagnosis or the working diagnosis. It helps us work up, develop a priority for our workup. In other words, which tests do we want to do first? Which are the most immediate or most priority things that we need to do first in terms of helping us come up with our diagnosis? And it also helps us come up with our management plans. Now, the management plans takes into account all of the information about your diagnosis. What is the best evidence? What is our the current guidelines? What do they describe for the management of this particular condition? And then, in addition to that, what the patient's needs or desires are and their resources, whether they have insurance, whether they don't have insurance. All of that is going to be taken into account in terms of developing your plan for the management of this particular problem. So let's talk about the steps in critical thinking. This is a little algorithm that is helpful in terms of helping you sort of see the process. If you look at the process of coming up with a hypothesis or your actual diagnosis and working plan, you first start out with your clinical examination and information gathering. That is your history, review systems, your examination, and then any other clinical findings such as laboratory data. You're going to organize and integrate this information into some sort of an assessment of all of this information. Then you're going to assign priorities, and that comes with your clinical judgment. This is where your clinical judgment comes into play. Clinical opinions, integrating preferences of the patient and the professional's needs will come into developing the next step. You have to look at your feelings, attitudes, and values, and then you're also going to look at probabilities and risks in terms of coming up with your decision. What are the probabilities for this particular condition? What are the risks for this particular treatment? Further assessment and balancing advantages with risks in light of the patient's and your feelings, attitudes, and values is the next step. And then identification of problems, as far as you want to be as specific as possible, which will lead you to your hypothesis formation and determination of your next steps. So, assessment, judgment, and evidence. Let's talk about that for a minute. That is bringing the decision-making, clinical experience, and knowledge of the patient together with the current best evidence regarding the issues involved. You're going to assess the information. You're going to prioritize what you see and find. You're going to form a clinical opinion based on your experience or that of your colleagues or your mentors. You're going to integrate the patient and professional preferences. For instance, if the patient prefers to have a shot versus oral medicines, or if the patient prefers to wait to have some expensive diagnostic test, if the patient refuses certain things, those all go into play in terms of your plan. Also, the professional preferences. All of us will develop preferences in terms of how we treat things. We will have our favorite medicines. We'll have our favorite ways of doing things that come into play in terms of our development of a plan. And then further assessments also will help you develop this final diagnosis. The problem identification is critical. A problem can be defined as anything that is going to need further evaluation and/or attention. It may be related to one or more of the following. So, for instance, if you really can't decide on a final diagnosis, if you have an uncertain diagnosis, you may wind up just putting a symptom because you haven't really decided what the actual cause of this problem is yet. You may have new findings related to a previous diagnosis. For instance, if someone's blood pressure has been very controlled and now all of a sudden their blood pressure is not controlled, and perhaps they've had very well controlled diabetes and now they're having some other problems. So that's related to a previous diagnosis. New findings of unknown etiology. You may have unusual findings that are revealed in the clinical exam or by laboratory tests, something that hasn't come up before. Or there may be personal or social difficulties of the patient. Well, we've all talked about and heard about hypothesis, but what is a hypothesis really? And I'm not talking about a hypothesis in terms of a research question. I'm talking about your hypothesis of what this problem is. The hypothesis of a patient's problems draws on all of your knowledge, experience, and reading about patterns of abnormalities and diseases. Now think about that for a minute. Patterns of abnormalities and diseases. All diagnoses and diseases have patterns. They basically have all of these things that fit together like a puzzle to help you come up with that particular diagnosis. What we do is select the most specific and critical findings that support the hypothesis, and we match these findings against all of the conditions you know that can cause these particular findings. And then you eliminate those diagnostic possibilities that fail to explain the findings. Patterns of abnormalities and disease. Looking at the competing possibilities, and you select the most likely diagnosis. You're going to weigh those competing possibilities. You're going to say, well, this doesn't fit because of XYZ, or this particular one really seems to fit all of the subjective and objective data that I have so far. That will help you come up with your diagnosis. You're going to always want to make sure that you include your worst case scenario in your list of differential diagnosis so that you can be sure that you have ruled it out based on your findings during your history, during your exam, and during the diagnostic evaluation with diagnostic data. So for instance, if your worst case scenario for a headache is brain tumor, you want to make sure that in your review of systems and in your past medical history, you're going to ask the patient if they have a family history of any brain cancer. You're going to ask about symptoms related to cancer or tumors of the brain. In other words, have they had any nausea? Have they had any vomiting? Have they had any vision changes? Have they had any abnormalities in terms of balance? Any weaknesses? All of those kinds of things would help you rule out the worst case scenario, or rule it in if that is the actual diagnosis. And then you're also going to consult the literature. You're going to look at the most current evidence to come up with your evidence-based decision making. You're going to select specific and critical findings to support your hypothesis. They form a pattern or cluster of symptoms. So for instance, the worst headache of my life is related to things that are very serious, such as brain tumors or meningitis, papilledema, meningismus, mental status changes, lead us more directly to a diagnosis of intracranial pressure rather than a migraine headache. So we want to look at those patterns and those clusters of symptoms. And we also want to look at symptoms. We want to match these findings against conditions that you know that can produce those signs and symptoms. So for instance, headache, papilledema, we would look at those symptoms against a list of conditions that we know can cause these symptoms. And then we're going to look at a list of conditions that affect intracranial pressure or compare symptoms of headaches against various conditions that might produce this clinical picture. For instance, vascular, metabolic, neoplastic conditions that can also cause this. We eliminate the possibilities that don't support your clinical findings. So, for instance, one of your differential diagnoses for headache might be cluster headaches, but this hypothesis should be eliminated because it fails to explain the symptoms. Bifrontal throbbing headaches with nausea and vomiting. Also, patient's pain is not the typical cluster headache pain, because a typical cluster headache pain is unilateral, and it usually occurs at the same time over several days, and it's associated with tearing eyes and runny nose on one side of the face. Those are typical symptoms of a cluster headache, whereas the other symptoms that this particular patient has presented with don't explain cluster headaches. So we're going to weigh competing possibilities and select the most likely diagnosis from among those that could explain these signs and symptoms. We're going to look for the closest match between the patient's presentation and typical case of this given condition. So you have to know what a typical presentation is in order to help you come up with this closest match and to come up with the most likely diagnosis. We're also going to consider statistical probability. You're going to look at the patient's age, race, sex, lifestyle, family history, etc. to help you in terms of probability of certain conditions. For instance, someone who is 25 years old who comes in with a cough and night sweats and fevers would give you a different picture than someone who was 70 years old with cough and night sweats and fevers. So your first thought for someone who is 70 years old might be carcinoma, whereas your first thought with someone in the 20s might possibly be TB. especially if they were an immigrant. We also look at timing of symptoms and presentations. They're very important in our differentiation. When the symptoms occur and in relation to what kinds of things. So timing is extremely important. Always make sure that you include the worst case scenario as you develop your possible explanations. You want to consider life-threatening or worst case scenarios. And make sure that you have ruled those out. Make sure you've asked all the right questions and ordered the appropriate diagnostic tests to sufficiently rule this out. But one thing to remember before you start chasing zebras is that common conditions are common and uncommon conditions are uncommon. So don't go looking for zebras when there's a whole pasture full of horses. Just make sure to remember common things are common. Now you're going to test your hypothesis. You may look at tentative diagnosis. So by coming up with tentative diagnosis, you may decide that you need to gather more history. You may need to do some additional maneuvers on the exam. You may need to order some laboratory studies or x-rays to confirm or rule out your diagnosis, or to clarify which of your several possible diagnoses are the most likely. If your diagnosis is clear-cut from the history and the exam, you may not need these extra steps, but oftentimes we have to come up with our tentative diagnosis, and then that is supported by our laboratory or x-ray studies or additional information that we may need. We establish a working diagnosis based on the highest level of explicitness and certainty that the data allow. Sometimes our working diagnosis may be a symptom, such as vomiting, because we do not always know the underlying reason for the vomiting. At times we may be able to define the problem in terms of its structure, process, or cause. For instance, if you have someone who comes in with a sore throat and you've been able to do a rapid strep test and it was positive, then you can have a definitive diagnosis. Routinely, make sure that you list health maintenance as part of your working diagnosis so that you can keep track of important health concerns such as immunizations, screening diagnostics, and things such as that. Advanced practice nurses are going to look at diagnosis and treatment of the disease, which is the medical diagnosis. We also look at nursing diagnosis, or in other words, what is the response of this person to this actual or potential health problem? What do we need to help them with in terms of how they are going to be able to cope with this particular problem? That comes into our education, our other resources that they might need, and so our nursing diagnosis is just as important in primary care as it is in your nursing in the hospital. And we also look at the diagnosis within the context of the patient's environment. For example, the family diagnosis. How is this particular problem going to affect the entire family? Are there likely to be issues? Do you need to bring the spouse in so that they can be involved in if it's a chronic disease such as diabetes? So we always be wanting to put it in the context of the family. Our next step is to develop a plan for the diagnosis. We want to always make sure that this plan is agreeable to the patient. Oftentimes I will say to the patient, here's what I would suggest. Is that going to work for you? So for instance, if I had somebody who had reflux and they'd been having reflux for several months, and we decided that we were going to treat it with a PPI proton pump inhibitor for a month and then reevaluate. I would basically give them my plan, and my plan would be, I'm going to prescribe this PPI for you. I want you to take it every day for the next month. Then at that, I would like for you to come back in a month and we'll reevaluate. If at that time you're still having major symptoms, it may be that we need to go ahead and do some further diagnostic tests. So that would be, so how do you feel about that? And is that agreeable to you? Our other option could be to go ahead and do the tests up front and make sure that you don't have an ulcer. Most of the time, but patients are going to say, well, I'd rather just try, the treatment first before I have to undergo these invasive tests. So you're going to give patients options, and you're going to, tell them what your recommendation is, and then together you will come up with the plan that is agreeable to you both. You're going to identify and record this plan for each problem. Now, some of you worked with me in the Women's Health Day. Others of you worked with the other instructors. The one thing that I hope you learned was that when you develop a diagnosis, and patients may have several diagnoses, you always want to have a corresponding plan for each of those diagnoses. What are you going to do about each one of those? So, for instance, if someone has a diagnosis of hypertension, how are you going to treat that? If someone has a diagnosis of degenerative joint disease, how are you going to treat that? If someone has a diagnosis of well woman exam, what on your plan corresponds to that? And oftentimes that is going to be basically education regarding preventive things, regarding what they need to be looking for at the next phase of their development, what other screenings you recommend and when, such as mammograms, etc., education regarding breast self-exam, and when they're going to follow up. Always make sure that you include follow-up in your plan. So if they were there for just a well child visit or a well woman exam, your follow-up may be return yearly. Or if they're a 2-month-old and they're coming in for a well child, it may be to return it at the 4-month well child visit. But always include your follow-up. In your plan, you would want to say if someone was there for an acute visit, such as a sore throat, and you decided that it was just a viral pharyngitis, you would say, if not improved in 3 to 4 days, return or call for further evaluation. So whatever it is, you need to include your follow-up in your plan. Always make sure that you also include any tests that you ordered that are going to help to confirm or further evaluate your diagnosis, any referrals that you made for that particular patient, whether it be for further evaluation of the problem or for another problem that they may have, or if it's for like a preventive type thing like mammogram or etc. Make sure you list the medications that you're giving. If you've changed things, added things, deleted things, make sure that you note that. And always, always, always make sure that you list your counseling and education, because as we all know, if it isn't documented, it wasn't done. And it's very important in terms of following up, other people following you up, and in terms of when you follow up that same patient, that you have listed those things that you did. It's also important for your billing purposes, because that supports the time that you spent with the patient. It supports the complexity of the visit and what you can charge for that particular visit. So these things are very important. Critical thinking allows you to consider and discard a variety of possible diagnoses, from the common to the rare. According to Kopp, there are at least 3 diagnoses for every disease. The one that unifies what you've learned, the one you cannot afford to miss, the one that it actually is. Sometimes they are all one, but usually not. Whether or not you have positive outcomes rely on the quality of your decisions, the soundness of your hypothesis, the actions that your hypothesis suggests, and how those actions are implemented. And then, of course, your sensitivity, one of the most important contributions to your outcome. Remember Occam's razor or elix, the law of parsimony, or the law of succinctness. All your findings should be unified into one diagnosis. This is not always true, because your patient may actually have more than one disease process going on at the same time. Possible barriers to critical thinking can be your feelings, your attitudes, your values. Also, mechanistic or deterministic thinking is governed by a sense that your knowledge must be certain. Our decision-making must have a balance between this and probability. The certainty in knowledge is impossible. Do not be dominated by a mechanistic assumption that there is a precise and discoverable cause for every event. The challenges of the clinical data is that we have a tendency to try to cluster things into one problem. And as I said before, it may be that there are several problems. Is it one or more body systems involved? Challenges also include the knowledge of disease patterns that are necessary. Some diseases involve more than one body system, and we may have multi-system conditions. Clustering, though, can be helpful, especially if there's multiple problems. Age helps you to categorize problems known to occur in that particular age group, and timing of symptoms helps us in terms of clustering data. When the symptoms started, the duration. For example, sore throat 6 weeks ago is most likely unrelated to fever and chills now. So we're constantly clustering things. Problems in one system or related systems can most likely be explained by one diagnosis, and problems in different unrelated systems may mean more than one diagnosis. Pattern of disease is necessary in clustering symptoms. Especially in multi-system disease, it helps decide differentials. For instance, cough, hemoptysis, weight loss in a 60-year-old smoker, as we talked about before. I'm going to end at this particular point, and I will resume with part 2 of this lecture.